So let's talk about colonoscopies here. Before I begin, absolutely a medical disclaimer. Anything I talk about here on this show is not medical advice. Please talk to your doctor before you consider to do or not to do any testing or making any changes in your lifestyle, which includes nutrition changes, supplements, exercise, whatever it is. Never change any medications without talking to your doctor who prescribed that medication. But this is just information only, and we are not forming any sort of a doctor-patient relationship on this show here. Talk to your doctor first. The reason I'm doing a show on colonoscopies is I am getting a lot of questions in my clinic about colonoscopies. And I'm not sure why I'm getting so many more questions. Maybe it's because I'm now of the age of colonoscopies myself, okay? So there's a lot of information to consider whether you're going to follow certain recommendations in the United States or you're going to follow recommendations in other countries and so forth. Here's some information. Number one. So first of all, it is a serious issue. So colorectal cancer is the second most common cause of cancer-related deaths in men and the third most common cause of cancer death in women. So it is a serious consideration on what to do here. The data I'm talking about right now is coming out of the Canadian Medical Association Journal, and this is an article that I came across on March 15th of 2016. You're going to see in a moment why I'm quoting that particular medical journal. Let's see, the lifetime probabilities of dying from colorectal cancer, men and women, is 3.5% and 3.1% respectively, 3 out of 100 for men and women above. Now, they also talk about most colorectal cancers seem to arise from the polyps that we hear about. So then, just in a simple concept, it makes sense that if you can detect the polyps soon and early and take them out, then you're doing some prevention activities there as well. Kind of makes sense, right? Well, let's talk about this and see if we come to a different conclusion. Okay. So the data on this particular article in the Canadian Medical Association Journal, March 15th of 2016, is from the Canadian Task Force on Preventative Health Care. Okay, so they're focused on preventing chronic diseases and so forth. Now, they changed the recommendation. So I've talked about this. This is 5 years ago now, where Canada basically said we're not recommending regular colonoscopies any longer. And let's see why. We recommend not using colonoscopy as a screening test for colorectal cancer, says the data in this article. So the general recommendation, so what do you do otherwise? And what they're talking about is in asymptomatic adults. Now, what they're saying is if you have symptoms, go get a colonoscopy, okay? So, but asymptomatic adults now, from ages 50 to 74, and we were just talking about before the show, that might be dropping in the recommendations might be dropping in the United States to 45 and so forth, is you can get a fecal occult blood test, FOBT, every 2 years. This is, again, the Canadian recommendation, or a flexible sigmoidoscopy, which tests the lower part of the colon and the rectum, and you do that every 10 years. One of the advantages of that is it's less expensive, there's less preparation, and there's no sedation needed for the sigmoidoscopy as compared to a colonoscopy, okay? Now, there was an article on NPR about this as well, dragging in the Canadian recommendations, which are different than the United States recommendations. From the U.S. Preventative Services Task Force, the type of screening should be a personal choice, they say. So even in the United States, they're not saying absolutely colonoscopy or hit the road. They're saying it's a personal choice, go through the data, talk to your doctor, here are the options and what they're talking about. It should be a personal choice made with consultation with the doctor. You can, one of the options is colonoscopy. Another one is the fecal occult blood test, FOBT, or a flexible sigmoidoscopy, are all screening options, says the U.S. Preventative Services Task Force. Some believe that colonoscopy catches polyps in the early stages. So here's the difference between colonoscopy and the fecal blood tests. Some believe that colonoscopy is going to catch the polyps earlier in their early stages before they become more of a problem or more chance of becoming malignant, where fecal blood tests are going to detect larger lesions that are further along. So that is something to consider when you're looking at these tests. So that's number one. Okay. Things have changed in Canada. Those are the different options and recommendations that are being made. Number two, and I suggest anybody that's really interested, go to this short video. This is from Dr. Michael Greger, MD. November 25th of 2015. His website is nutritionfacts.org, nutritionfacts.org. He has this video that I'm talking about here is a 5-minute video. It's really interesting about information. It's about gathering information with your doctor. The first thing that he opened up with is he said, don't forget, the procedure itself, colonoscopies, comes with some risk. There are 2.8 per 1,000 serious complications from colonoscopies during the screening process itself. It can cause serious harm. The more common one is colon perforation. You actually poke a hole in the colon. That's really bad when that happens, okay? It's possible, okay? 2.8 in 1,000 is something that happens there. If you get the flexible sigmoidoscopy that I mentioned earlier, the risk of those serious harm problems drops tenfold. So that's another reason to consider other testing is the flexible sigmoidoscopy is 10 times safer as a procedure than colonoscopy. So what about the risk benefit? Nobody really knows yet, as he talks about, Dr. Michael Greger, because no randomized controlled trials have been finished yet, and they won't be finished until the mid-2020s. So here we are in 2021. We've got a little bit more time to really know the answer of the risk-benefit. Is it really worth it with colonoscopies, in particular, compared to other tools? So that information's coming, but it's just not here yet. Okay. So once again, he's quoting the U.S. Preventative Task Force recommendations, ages 50 to 75. They're talking about that you can have an FOBT, the fecal blood tests, annually, or a sigmoidoscopy every 5 years, or a colonoscopy every 10 years. So again, those are the options that are presented. It's a personal choice. You talk to your doctor, you gather the information, and you make a choice. This is, again, for asymptomatic individuals ages 50 to 75. Okay. They are, so what happens after that? Ages 76 to 85, don't screen routinely. Again, if you have no symptoms and you've been screening negatively. And if you're over 85 and over, don't screen at all. Again, if you've been screening negatively. Okay? All right. So what to do is at the end of the video that Dr. Greger did here. You need to discuss the risk and benefits with the doctors now. This gets really interesting in his video. I want to talk about this. Okay. So you need to have a risk-benefit communication with your doctors. Okay. And what researchers did now, this is published literature. He has the documentation on his YouTube page. Okay. On this video. What they did is they audio taped the clinic visits between the patients and the doctors. So they literally audio taped them to see if the 9 elements of informed decision-making were being met. There are 9 elements of informed decision-making that should be discussed between the doctor and the patient. 9 of them, we don't have time to get into them, but I'm just going to list the words. Role, context, the nature of the procedures and what you're trying to accomplish, the alternatives that might be available, pros and cons of the procedure, the uncertainties with the procedure, the understanding that the patient might have, the input from the patient, and what the patient's preference is. Okay? So there's 9 elements of informed decision-making in this back and forth. The conclusion of the audio tape discussions, guess how many of those 9 elements were met on a routine basis? For a lot of them, it was 0. On average, it was 1 of the 9. So basically what Dr. Greger was saying is a lot of patients are leaving it up to the doctor. I'm not saying that that's a good or a bad thing, but you can imagine that leads to a lot of colonoscopies, okay? That's number 2 in dealing with the issue in colonoscopies. Number 3, if you want to do a deeper dive on colonoscopies, you can go to Dr. John McDougall's website, another medical physician, go to drmcdougall.com. On his website, he's got lots of articles, lots of videos, lots of information there. He's got a nice search engine, and in this search engine on drmcdougall.com, you can put in colonoscopy. One of the first hits will be a video that he did in September of 2016. It's a 35-minute video. And what he's going to talk about in there, and I kind of agree with this, is a lot of the testing should not be considered prevention. If you test and you catch something early, that is early detection. Early detection is not prevention. Prevention is you never get the X. Early detection is you get the early X, but maybe cut it off before it becomes a more major situation. Now, of course, that's a good thing too. But if we back up a little bit more, we know that just like most cancer, not all, but most cancer is preventable. Most cancer is not spontaneous genetic mutations, although sometimes we're led to believe that bad genes were given to us and then we got sick. That's a concept that some of us do have. When we realize that it's actually the main ingredient here is our environmental choices, what we do with our own bodies that will determine whether we go down a disease track or we don't go down a disease track, okay? So Dr. McDougall will talk a lot about prevention and not early detection, okay? Then, so again, if you want to do a deeper dive in what to do there in the prevention categories, of course, you can go to my old cable television shows, you can go to my YouTube page, and I talk a lot about cancer prevention, including colon cancer prevention. When I was doing a little search and preparing for the show, I just did a search on preventing colon cancer, and this is right off the Mayo Clinic's website, and they talk about things that we need to address in preventing colon cancer significantly. The typical Western diet adds risk to colon cancer, or what we call the standard American diet, or the SAD diet, which is low in nutrients, low in fiber, high in sugar, high in processed foods, and so on and so forth. How do you change that? You add more vegetables, you add more fruit, and you can add more whole grains is what the talk is, although some people say eliminating grains, but we'll visit that another day. So that's the first one, is changing what you're putting into your pipes will change the health of your pipes, okay? Secondly is a sedentary lifestyle. So if we're not moving around, we actually get more risk of all cancers, including colon cancer. Third is diabetes, specifically type 2 diabetes, which we know is nutrition and exercise related. Obesity, which is, again, related to the entire thing. It's the nutrition thing and the exercise thing. Smoking, if you're a smoker, you increase your risk of all cancers, but colon cancer in particular. And then alcohol, don't overdo alcohol. So you can see that there's wonderful prevention strategies built into the discussion here. So even if somebody decides to do colonoscopies on the suggested United States recommendation series of ages 50 to 75 or 45 to 75, whatever it may be, wouldn't it be nice that every single test that you have, whether you do the fecal occult blood testing and or the sigmoidoscopy and or the colonoscopy, that all the tests come up clean as a whistle every single time? How do you increase the chances of that happening? You employ these prevention techniques. And lastly, the last thing that wasn't talked about here, which would be the nutrition and the exercise, which is related to all these other things, and don't smoke and limit your alcohol intake, is chronic stress. And most of these articles don't address chronic stress. The one thing I want to mention about chronic stress is not only dripping those stress chemicals onto all the cells of your body, which does really bad things from a genetic expression scenario, but keep in mind that the more chronic stress you have, the more you increase your sympathetic nervous system, and the more you shut down the parasympathetic. Now remember that sympathetic is fight or flight, okay? Parasympathetic is rest and digest. Sympathetic shunts the blood to your extremities so you can run or fight. Parasympathetic, and that would be your stress response. Parasympathetic shunts your blood to your stomach. And one of the things that you need to have healthy tissues anywhere is good blood flow. So if you're consistently under chronic stress, you're taking the blood away from the gut and into your extremities, and that's a bad thing. the more we employ techniques and tactics, which I've talked about a lot here on prior shows, on reducing our chronic stress, we're going to improve the blood flow, nerve activity to our gut. Now that can be very important in this whole subject matter. I'm Dr. Scott Fuller. Thank you.